You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Be sure to follow the podcast on your favorite app so that you never miss an episode.
In this episode, we explore the transformative power of point-of-care ultrasound with Dr. Victor Rao, a radiologist, educator, and internationally recognized leader in ultrasound training. As the Global Clinical Content Manager and POCUS Educator at Inteleos, Dr. Rao has helped shape the way ultrasound is taught and used across the globe. His work spans clinical practice, curriculum development, and international outreach, including pioneering the POCUS curriculum at the University of South Carolina School of Medicine and bringing tailored training programs to underserved regions like Tanzania, Haiti, and the Philippines. Quality supplies make a difference. At EDM, our mission is to help you enhance patient care. For over 30 years, we have been a leading supplier of medical imaging products and accessories. It all started with one product, Crystal Ultrasound Gel. And now our catalog includes over 300 products designed to support your practice. From probe covers to needle guides, EDM Medical Solutions is the partner of choice for over 2,000 healthcare facilities in the U.S. Learn about our range of ultrasound solutions on our website by visiting us.edm-imaging.com.
Today, we're delving into the global impact of ultrasound, specifically point-of-care ultrasound, or POCUS, and how it's reshaping healthcare delivery in underserved regions. Our guest is Dr. Victor Rao, a radiologist, educator, and internationally recognized leader in POCUS training and curriculum development. Dr. Rao currently serves as the Global Clinical Content Manager and POCUS Educator at Inteleos, the certifying body behind ARDMS and APCA. His career spans primary care, radiology, and a groundbreaking commitment to medical education. He's trained thousands of healthcare professionals in the safe and effective use of POCUS across hospitals, universities, and clinical settings around the world. At the University of South Carolina School of Medicine, he pioneered and implemented the POCUS curriculum for both medical and PA students, developed e-learning and CME programs, and helped shape the next generation of ultrasound-guided care. During his time there, he was also an assistant professor of radiology. Internationally, his work has brought POCUS education to places like Tanzania, Haiti, and the Philippines, adapting training to meet the needs of clinicians in resource-limited environments. Dr. Rao is also a respected academic voice. He has authored and co-authored numerous peer-reviewed articles and textbook chapters on ultrasound education, point-of-care imaging, and high-intensity focus ultrasound. Dr. Rao, it's a privilege to have you on the show.
Happy to be here. Thanks for inviting me.
So let's begin with the global side of your work. According to the World Health Organization, 2/3 of the world's population lacks access to even basic imaging services. That makes innovations like portable ultrasound essential in closing diagnostic gaps, right? Can you share your experience training physicians in underserved areas like Tanzania, Haiti, and the Philippines? What kind of challenges did you face when introducing POCUS in those settings? And how did you adapt the training to local needs?
Yeah, those are great questions. The challenges when I went to train individuals in those countries, I was expecting some challenges like logistical challenges or perhaps lack of equipment, but that wasn't the case. They had equipment. What was really missing was the lack of personnel to train individuals and to, you know, make them comfortable with the diagnosis that they want to make. And so that's, in fact, is also a challenge, even in the United States. That's what's really missing is the lack of trained personnel. Even in advanced centers, we find that we don't have enough folks who are trained attendings who are very well trained in ultrasound. We train medical students, but the attendings and residents are not comfortable with the idea of doing ultrasound. So therefore, there is this deficiency over there. So what was really the bigger challenge? They had unique challenges. So the Haiti, when we went to train Haiti, um, it was a very beautiful experience, I would say. The faculty, we joined other faculty members who went with me, and they were also enthusiastic to learn ultrasound. They're all physicians from Haiti, but they were hungry to learn, and that was the most beautiful thing. They really wanted to learn, and the sad part is that Haiti, as you know, has that political instability. So even after we trained those individuals, they had to flee Haiti. So that was the sad part because things got so unstable and so dangerous that they had to leave. But the good news is they have a skill that they learned, and they perhaps will apply in neighboring countries where, or maybe one day when things are stable, they may come back to their home country. The In Tanzania, it was a really great experience because the way we did the training was I did the lecture and then the hands-on experience for the physicians, and then following that we did the grand round. So we actually went into the hospital, to examine patients and help them solve the problem. For instance, we had some examples I'll give you. Like one patient was there. They thought the patient actually had a PE, pulmonary embolism, and they thought that the patient is very, very sick. And patient did look kind of sick. She just delivered a couple of days ago, and they were concerned that she has a massive PE and may die. But when we performed the point of care ultrasound of the heart, we noticed that the heart was totally fine, and there was no evidence of a large PE. It could have been a tiny PE, but there was nothing CSP. So that was kind of reassuring for the patients and as well the faculty and staff over there. So all these places, I was really shocked, and also encouraged that everyone was wanting to learn the point of care some skills. And we found ability from one patient to the next. Like we had another patient who they had that they thought patient may have a DVT in the leg because they had a swelling in the leg and it kind of looked like a deep end thrombosis. And so they were really concerned. But when we did the ultrasound, we just saw that the patient only had free fluid or some fluid between in the interstitium of the tissue, in the skin and the subcutaneous tissue, but they didn't really have any evidence of a deep vein thrombosis. So it was very reassuring, because otherwise you may wonder what's going on, or you may want to start anticoagulation, and that itself has a set of problems. So it's really a game changer to be able to use point of care. So sometimes you're making a diagnosis, sometimes you're eliminating a diagnosis. So you say thinking something is wrong, and then when you do the ultrasound, you don't see any evidence of that condition. So clearly that's out of your list, because whenever as physicians, when we see a patient, we don't really make a diagnosis like that's the diagnosis the right way. Sometimes we do, but most of times we have happens that we are actually having a list of differential diagnoses. You have like 4 or 5 diagnoses. And then one by one, we work through it. We do CAT scan, MRI, X-rays, lab tests. And then eventually, let's like a detective, we kind of solve the problem and we remove something and say, okay, this is the diagnosis because all the evidence is pointing in this direction. Um, so that was a really beautiful experience in Tanzania. And then the third one was Philippines. Philippines was actually a medical school, and it's a pretty prestigious medical school, University of Santo Tomas in Manila. And they had a really huge class size, about 1,500 students in a class. Really huge. It was so huge, I couldn't believe it. And because normally in the US, we have schools like 50 to 100 students, in a school, in a class, or maybe the max 200, 300. That's it. Or it was 1,500. And so also was really excited. The faculty was so excited to learn this. So they also, at that time, they got funding and they got a grant. And so they actually acquired equipment. And so it was kind of nice to be able. And right now, I'm happy to say that they have a well-developed ultrasound training program, over there in Philippines. Tanzania, unfortunately, things didn't go the way they should. So there was a change in the administration. The new administration felt differently about point of care ultrasound, you know, and so they didn't want to pursue it. Or at least when I went to the website, I don't see any evidence or proof of point of care ultrasound being done over there. Maybe it is, but there's zero mention. And the earlier it was. The Haiti physician actually contacted me just few days ago, and he has moved to another country. And all the physicians that I train also moved to the country, so they are coming or going point of care science sections. So that's the challenge. So yeah, but we keep going on. I think that is what it is. But I think training is the key. So we must train individuals and empower them.
Right. I mean, it's incredible. And I think, especially for the audience, which the vast majority is stateside, it's incredible to hear these stories, right, of the impact that focus training can have, that clinicians such as yourself are having through these programs, because there is an interest, as you say, in the modality, but there's just a lack of training sometimes, right? And it's that lack of the availability of quality training that at times causes a barrier. In addition to barriers of adoption from administrations like what you mentioned, which of course is something always an extra obstacle that's difficult to overcome. Now, you mentioned a few already, but I'm sure there's been a lot of truly rewarding moments in being able to pass on that knowledge to clinicians who are really eager to start using the modality that perhaps sometimes we take too for granted in the US. They're very eager to use it to help their patients. And so, I'd love to hear more about what some of the most fulfilling aspects have been of teaching POCUS abroad, especially when it comes to the immediate impact on patient care. I know you already mentioned the PE case, which was really interesting to hear about. Do you have any others that you could tell us about that really solidify the benefits of using POCUS globally, not just necessarily in underserved regions, but also around the world, simply because it's a great modality that allows us to have more diagnostic precision?
Yeah. So actually, the stories are endless. The more you do ultrasound, that's what I always tell my students as well. That it's because medical students would volunteer to be scanned, and I was surprised. I mean, we shouldn't be surprised, but I was surprised that even in medical students, we found conditions that they were unaware of. We had a medical student who we found, and by the way, uh, that is the question a lot of people ask me and are questioning that are the students good enough? Do they have the right amount of experience that can they diagnose condition? And surprisingly, first year medical students were able to tell me that something is not right, and that is the step one. So we teach them how to identify normal anatomy, what the structure should look like. So if the shape is different, or the eco texture, or the way it's appearing ultrasound is different. Is it too bright or too dark? Or there are some cystic lesions, or there are micro patients. We had students find abnormal area in one of the students' thyroid gland, and turned out, and when I looked at it, it's actually it was a case of papillary carcinoma, and so that patient, that student obviously was not too happy because nobody wants to be having that kind of diagnosis made. But if you look at it, it saved her life because she got treatment done, and then one day the student did come back to me and she said, "Thanks so much for making diagnosis and helping in the right direction." So in fact, one good example is this was nothing as bad, but there was a medical student who actually had back pain for the past 4 or 5 years. And when we were scanning, and he was taking pain meds for back pain, and a physician had diagnosed as backache, and there was pain meds on me. And when we did ultrasound, he was surprised. The patient, that student actually had a large diagonal calculus, had a large stone inside the kidney. That's what was causing the pain. And so ends up that the student went to the physician, they got a test done, and they had a surgery. He had a surgery done, and the student is off pain meds and is totally, you know, has no complaints whatsoever. So these are so many examples. And one other one that I have that I really mentioned, I was training a physician, and one of the patients came in, and she just had abdominal pain, lower brown pain, nothing else. And so when we scanned, we were surprised the patient was pregnant. The patient was unaware that she's pregnant. Can you believe that? And then we told her, "You're pregnant." She's like, "What?" He's like, "Yes." And this patient then told us the history that she has been pregnant several times and she always had spontaneous abortion. You know, when we look at the internal os, the reason why she was having low down discomfort and pain is because her internal os was open and the patient ended up tunneling. So that means the membrane had gone through, and this patient was about to abort. So we quickly scheduled the patient for circulage, which is a procedure. We would basically tie like circle around, like s- uh, or, a thread or something around the cervix, and to kind of close cervix, those interns. And that patient eventually did go all the way to term and delivered a normal, healthy baby boy. You know, so so many stories. If you start doing point of care ultrasound and you get comfortable with it, um, there'll be a very difficult. It will be difficult for you to be practicing medicine without ultrasound. If you tell me, if I worked in mission hospitals, at that time there was no point of care ultrasound. It was crazy because the patient was down and we had to just clinically determine what it is, and then we do a surgery or we do a cesarean. Then we find something that patient are totally unaware, and and this is a big shock to us. The patient's bleeding like crazy. So that's what I'm saying. Those are things that can be totally avoided, and that's what is going to help. As a result of those, if we can diagnose condition like placenta previa, placenta preta, and actually lower the maternal mortality rate. I was looking up the numbers recently. Maternal mortality rate per 100,000 in the US is about 80 to 20. Uh, in Africa, some areas, it's like 550. So 400,000. No pregnant woman should be dying at that rate. In fact, we shouldn't have any mortality. So this is what we're talking about. Point of care has the potential to lower mortality rate, to be able to save a lot of these patients who are dying necessary. And therefore, uh, I mean, I can't imagine practicing medicine ever without ultrasound. If you're handicapped.
If you are high-level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Old can high-level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Old. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show. I think it really serves to show that ultrasound, point of care ultrasound specifically, right, gives physicians an enhanced vision. Like you said, it's really a game changer. That's something that we've talked about with many of the guests on the show, is the way that POCUS is a game changer for diagnostic precision. And it really is having a transformative impact in medicine, right? And expanding the ability of more and more clinicians to use the modality. It's incredible to just fold it in your hand, and there's not even a cord. You have these cordless ones, right? It's truly incredible. And if we go into the conversation of AI, I mean, we could be here all day, right, talking about that. Of course, technology alone isn't enough. It does have to be feasible in many settings. The truth is that the challenges aren't just the training aspect, it's also equipment costs, maintenance, the need for buy-in for the broader clinical team and the administration. And one 2022 study actually highlighted that nearly 40% of donated devices in global health projects are underused due to training or repair issues. So, really looking at this under-resourced region environment, what specific hurdles have you had to overcome when bringing ultrasound to the field, whether that's equipment cost or logistics? Because we hear often of how POCUS is so much more affordable. I'd love for you to just give us more insight into the practicality of implementing it in these areas that are in such need.
Yeah, even though the price has gone down, when we first started doing this laptop devices, it used to cost about $80,000. Now they come down to what, 22,000. What the smaller ones that we have, like the little probes that you connect to your smartphone or your tablet. So those cost about $2,000 or $3,000. But sometimes I would say that still there's a prohibitive cost for some regions, but it definitely is not as expensive anymore. So that is the not really a challenge, but it could be. You know, but I think the main issue is going to be the lack of training and being comfortable making a diagnosis, because a lot of times folks are not that comfortable. So the mentorship programs, could it be online or on site? But those have to be done. Remember that the hand also is a hands-on modality, and now we're talking about AI. AI is good. I love the idea of the AI. It can definitely boost your confidence, especially when there's nobody around. So it can say that, maybe this is what it is. But AI can only provide some solutions when it can't make all the diagnosis for you. And I disagree with some individual, because I think eventually, as physicians or clinicians, we have a moral obligation to learn the skills so we actually can save a patient's life. I don't want that we are relying totally on AI to tell neurons. Eventually, the burden falls on the individuals to perform the scanning, and the more you do, the better you will get it. So it's all about developing. Some individuals have a better hand-eye coordination skill, so they are going to visualize or have a spatial orientation that's better than other individuals. But eventually, you'll get like. And I think the real challenge is uh, when people try to do too much. So try to find out what is really the problem in a community. What are the diagnoses that we are missing? What's happening, why are the patients dying, like the maternal mortality rate, what is the main cause for that, and then try to tackle that, and then take baby steps, and then come and forward. Because once you learn few things and get comfortable with them, then you can add more skills, right, to your knowledge space. Yeah.
That makes sense. I mean, you touch on an important point when you talk about AI because there's a certain debate, right, in the medical community and more specifically within the medical imaging community when it comes to the use of AI as an assistant, also the use of AI as a guide, right, during the actual scan, because there's more and more softwares that are being developed and released to try to have someone who's a novice who doesn't really know how to use it, right, be able to complete the scan. So I would like to hear what your thoughts are on that because perhaps some people would argue, well, Dr. Rao, in these areas, training is so limited. Shouldn't we just implement those programs to be able to get more clinicians using it? What would you say to them?
I think that's a good point. So if you have a challenge like that, so that's a solution. But eventually, I think that's where I come in, or where my organization comes in. We must do proper training and certification to validate what we're doing. Because the more dangerous thing is you're reassuring a patient that you're fine, you know, and you actually need a diagnosis, and that can lead to serious consequences. So that should never happen, because I remember one patient. This is I was in that hospital, but somebody told me about that. The patient came with chest pain, and they did a bunch of tests, and they told the patient, "You're good to go." And the patient dropped dead in the grocery store. They missed the diagnosis. So stories like these should not happen. Therefore, it's so important that we are very well trained, so we do our job right, and that's where the training comes in and the certification. Of course, there is no certification out there that can 100% guarantee, but at least when you prepare for a certification exam, gonna sit down and study, right, and then you get a list of topics or curriculum. You try to cover those. So at least the very least you've been through all that. And then it had some hands-on experience. So you had some validation of that from your peer reviews. And then you go to the exam and you submit images and videos. That's what we have. So, and by the way, a lot of times I've seen when I'm reviewing videos and images, I find a lot of mistakes. That's what it's all about. It's supposed to be a more of a constructive mechanism to help individuals fix the problem. So if they're measuring certain things wrong, and incorrectly, so I guide them that this is the right way to do it, and then they resubmit and they're good to go. if they have the wrong parameters or some, because if your image is too dark, say gain settings so low, you can miss a bit. So it's too bright. So those are things that we provide feedback, and then that's really helping individuals improve their scan technique. That important, because if your images are wrong, if your scan plane is wrong, you can totally miss a diagnosis.
That makes sense. No, there really is such a need to have validation and to ensure that we're scanning correctly, right? And I think that the concern or the apprehension is justified, right? Where it's like we really need to prove that this software is doing the right thing. And of course, one of the best methods for that is what you said, to have properly trained individuals. It's a real safeguard, right? Now, looking ahead, what's next, right? When we look at the future of POCUS in global health, what's your outlook on the role of POCUS in different global health initiatives moving forward? And how important would you say international collaboration is in expanding access to this valuable resource?
Yeah. So I think not just internationally, but nationally as well. You'll be surprised. There's so many areas within the U.S. Rural areas where there's no hospital or no advanced centers. I'd actually trained physicians in those areas, and they would tell me that there's no hospital for next 100 miles. You know, so they can't get any of those X-rays or ultrasounds. So it really makes a huge difference if we can provide that kind of service right there in the community itself. So patients can get their scans done right there, the clinics where they go, where the physician has the office. So it's a huge makes a huge difference as a game changer. So that is really going to be the thing, and I think AI, as you mentioned, those things are there, but we still must learn it, and it's good to have the AI. So I'm not opposed to it. I definitely love the idea of having AI giving me us a little bit of reassurance. So and also sometimes AI is guiding me through a protocol. So it's very helpful. So internationally, I think huge difference, as you know, that there's a huge gap, and there. So we can have there are maybe one radiologist for 400,000 population. This is impossible to fetch one radiologist take care of it. So we had to empower the nurses. That's what, even the US, I think that's my thought process. I think the nurses, since they are there with the patients, and the healthcare workers, midwives, so that is a plan of our organization as well. Inteleos, so we are trying to empower individuals in Africa and the countries so they can actually be able to, so we give them short protocols, and we also validate their knowledge, have a certificate exam for them, and also the instruments on training. So it's so important because we cannot have a global impact. We cannot until we actually expand Dolby and every. My dream actually, and I think everybody's dream is, and who is involved in Focus, is that point of care ultrasound should be a device in the hand of every clinician. You could be a small healthcare worker in a small rural area, it's gonna make a huge difference because you'll be able to obviously not make the greatest diagnosis or more complex diagnosis, but most of the people are dying of simple things, you know, just able to tell that this patient has a tamponade or cardiac tamponade, or this patient actually has congestive heart failure versus COPD, just very simple things. I was recently talking to a colleague in the US, and they were telling me that a lot of patients are getting discharged and they're back in 2 days. And the reason being that they were not ready for discharge. So that's very simple. Just put the probe on the patient's chest. And if you see a bunch of B lines all around, that patient shouldn't be going home. They just give oxygen and send the patient home, and the patient come back after 2 days because the patient had lots of fluid in the lung and it wasn't ready for discharge. But when those disappear or we have minimal B lines, a lot of A lines in there, so that means the lung is very well aerated, then that was a higher chance of success. So to have the a really positive impact, I think the global community has to be involved. And also, I had this kind of mentioned one time that must involve the local governments, or the healthcare system, because we must get a buy-in from each of the individuals. Yeah.
In addition, what you mentioned, in addition to the patient outcomes, then there's also a certain financial aspect, right? Where it could really help our healthcare system be more efficient. Like you said, you have a patient coming back. So there's also those implications, I think, for administrations that need to be taken into account a greater degree of awareness, right? We've had other guests talk about that too, that perhaps there isn't still yet sufficient awareness to realize that this modality could be very, very beneficial in different healthcare environments, especially our hospital systems. And like you said, underserved areas in rural parts of the country, which also sometimes don't even have the sonographer. I mean, we're already struggling with a sonographer shortage, with a radiologist shortage. To be fair, in most clinical areas, there is a shortage, right? Even with nurses. So it's really important, I think, from what you're saying, for us to be aware that we need to leverage resources, even here at home, to be able to have a more efficient healthcare system. So, really great insights from you, Dr. Rao. Now, for those listening who might want to follow in your footsteps, longevity and sustainability are essential for any global health effort, and studies repeatedly show that when local partnerships and training are prioritized, programs do last longer and have a deeper impact. So, could you tell us briefly what key lessons have you learned from your global work that could help others, maybe others who are listening to this episode, launch similar POCUS initiatives or participate in them themselves?
Actually, I had a personal experience with this. So we were training some physicians in rural South Carolina, and when I went to one of his office, tried to teach him about ball bladder and aorta. He was like, I like to do a lot of OB, and that's the population that I'm serving. I'm doing a lot of deliveries. I want to be able to figure this thing out. There's no ultrasound system available, and there's no facility available for that. So we pivoted, and he said, okay, so we're going to train you on OB ultrasound, and very few difference. And so that physician, he was not too excited about it, suddenly got very excited, and then he applied for a grant, we got equipment, and so I'm going to say that now they have ultrasound available right in the rural village in South Carolina. So that's what I'm saying. You don't want to force something on people. You want to give what they want to learn. So I think the best love lesson for me on everybody is that you communicate with the community leaders and also the physicians and the clinicians, and you ask them, what is the problem that you're facing? What was the diagnosis that you are not able to make and leads to serious consequences or increase in maternal mortality or mortality in general or morbidity? So they will let you know that we have this problem. We can't figure this out. We don't have access to this behavior, this diagnosis, and it leads to significant delays and causes problems. So once you understand what the problem is, then you can go about solving it. But another thing that I learned is don't try to do too much, because if you try to give them 100 lessons, they're just not going to leave. So we had done to tackle the big ones first, and once they were profitable, but obviously start with the basics. So you was teach you be able to recognize this is normal, right? And this is not normal. And with time, it's going to come naturally. So it's because all physicians, clinicians are more or less, they have a lot of clinical experience. And now it's a matter of putting it all together in the context of ultrasound, and nothing like it. And then you use a stethoscope, right? Because it's so stretch it hard, but that is so much more difficult, especially when trying to determine some very difficult diagnosis in the heart, some valve disease or something. But the ultrasound, you can see the heart, you can see the chambers, you can see the valves, you can see the blood flow through it, you can see there's irritation happening, you can see the valve is incompetent, So it's a much more easier modality, and actually we have a higher rate of success there.
So interesting. Dr. Rao, thank you again for sharing your insights, your work, all of the great and valuable lessons that you've learned on the field, and for sharing your heart too for global healthcare. We're grateful for your time and for your ongoing commitment to the mission. Thank you.
Thank you very much.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.